Basics of Medical Biochemistry. First edition, 2022. Chapter 8. Biochemistry of the Gastrointestinal Tract. Part 2 of 2. By Professor Dr. Muhammad Jawad. MBBS, Tao, M. Philosophy, Ph.D., Dip M.E. Head of the Biochemistry Department-Fazaia Ruth Pfau. Medical College-PAF Base Faisal-Karachi-Pakistan. Ex-Professor of Biochemistry, Qassim University Kingdom of Saudi Arabia. Ex-Professor, Head of the Biochemistry Department and Vice Principal. Liaquat College of Medicine and Dentistry and Fatima Jinnah Dental College, Karachi, Pakistan. 8.5 Digestion of proteins. Sources of proteins include the following. 1. Endogenous proteins. These are secretory proteins contained in digestive juice and components of desquamated cells. 2. Exogenous proteins. These are the dietary proteins like albumin and globulin, egg, gliadin and leucosin, wheat, nucleoproteins, mucin, elastin, collagen and gelatin, meat and other animal-derived foods, legumin, pea, oryzanin, rice, caseinogen, milk, zein, maize, etc. Most of the nitrogen in the diet is consumed in the form of proteins. Amino acids are not stored by the body, i.e., no protein exists whose sole function is to maintain a supply of amino acids for future use. Therefore, amino acids must be obtained from the diet, synthesized de novo, or produced from normal protein degradation. Dietary proteins are chemically long chains of amino acids bound together by peptide linkages. The characteristics of each protein are determined by the types of amino acids in the protein molecule and by the sequential arrangements of these amino acids. About 70 to 100 g of protein is consumed each day, and an equal or larger amount of protein that enters the digestive tract as digestive enzymes or in sloughed-off cells from the intestinal epithelium is converted to amino acids by digestive enzymes. Proteins are hydrolyzed into amino acids by proteolytic enzymes that are produced by 3 different organs: the stomach, the pancreas, and the small intestine. Digestion of proteins in the stomach. The entry of food into the stomach and vagal stimulation by sight, thought or smell of food causes the release of gastrin hormone. Gastrin hormone stimulates the secretion of gastric juice having the following components. Hydrochloric acid, HCl. It is secreted by parietal cells. It maintains a pH of 2 to 3. It kills some bacteria and denatures proteins, thus making them more susceptible to subsequent hydrolysis by proteases. Its main function is the activation of pepsinogen. 2. Pepsinogen. Chief cells secrete an active zymogen called pepsinogen. This is an acid-stable endopeptidase, activated by HCl or autocatalytically. It releases large peptides and a few free amino acids. It hydrolyzes the peptide bonds formed by aromatic amino acids. 3. Renin. This enzyme is found only in an infant's stomach and its optimum pH is 4, infantile stomach pH, and causes coagulation of milk. Milk clot prevents the rapid passage of the milk from the stomach and gives to baby the sense of fullness. Renin acts on casein, the main milk protein. In the presence of calcium ions, renin converts casein into insoluble calcium paracaseonate, milk clot. The digestion of calcium paracaseonate is completed by pepsin. 4. Gelatinase, the enzyme that digests gelatin. Digestion of proteins in the intestine. The entry of acidic chyme into the small intestine stimulates the release of hormones secretin and cholecystokinin, CCK, and the enzyme enteropeptidase. Secretin. It stimulates the release of pancreatic juice rich in bicarbonate to neutralize gastric secretion. 2. Cholecystokinin. It stimulates the release of pancreatic zymogens, trypsinogen, chymotrypsinogen, procarboxypeptidase, proelastase and procollagenase. 3. Enteropeptidase. Enterokinase. It is chemically a serine protease, synthesized and found on the luminal surface of intestinal mucosal cells, i.e., enterocytes of the brush border. It initiates the activation of pancreatic zymogens through the activation of the trypsinogen into active trypsin. Active trypsin has autocatalytic activity, and activates not only the remaining amount of trypsinogen, but also activates the remaining pancreatic zymogens.
Figure 8.16 Activation of proteolytic enzymes in the intestine. Proteolytic enzymes of pancreatic juice. Trypsin. Trypsin is secreted as an inactive proenzyme, trypsinogen. Trypsinogen is activated to trypsin at first by the enterokinase, produced by intestinal mucosa, then by autocatalytic action of the formed trypsin that activates the remaining trypsinogen. Figure 8.17 Digestion of proteins in the gastrointestinal tract. Trypsin is an endopeptidase that hydrolyzes the peptide bonds formed by basic amino acids, example lysine and arginine. Trypsin also acts as an activator for all other inactive pancreatic enzymes. 2. Chymotrypsin, it is secreted as an inactive proenzyme. Chymotrypsinogen is activated by trypsin. It is also an endopeptidase that hydrolyzes the central peptide bonds formed by aromatic amino acids. The optimum pH for both trypsin and chymotrypsin is 8.0. 3. Carboxypeptidase, it is secreted as inactive procarboxypeptidase and activated by trypsin. It is exopeptidase. It hydrolyzes peptide bonds adjacent to the free COOH group of the polypeptide chain, releasing each time a single free amino acid. 4. Elastase, it is secreted as inactive proelastase and activated also by trypsin. It is an endopeptidase. It hydrolyzes the peptide bonds formed by small amino acids, example glycine, alanine, and serine. V. Collagenase, it catalyzes the hydrolysis of collagen. Proteolytic enzymes of intestinal juice. Aminopeptidase, it is an exopeptidase that hydrolyzes the peptide bonds adjacent to the free NH2 group of the polypeptide chain, releasing each time a single free amino acid. 2. Tripeptidase, it hydrolyzes the tripeptides. 3. Dipeptidase, it completes the digestion of dipeptides by breaking them into 2 amino acids. 4. Prolinase, it acts on the peptides having proline as the terminal amino acid. All these above enzymes are found in the brush border of enterocytes as well as in the shed enterocytes.
8.6 Absorption of proteins. Dietary proteins are usually absorbed as amino acids, after complete digestion. As amino acids are the end product of protein digestion. Absorption is rapid in the duodenum and jejunum but slows in the ileum. A small number of unchanged proteins such as peptones, proteases, and polypeptides may also be absorbed, as evident by allergy to some proteins. In infants, antibodies of maternal colostrum are absorbed as such. They contribute to passive immunity. Some dipeptides and tripeptides are taken up by proton-linked transporter. The absorbed amino acids chiefly pass through the portal system, but a negligible amount may also enter the lymphatics. Absorbed amino acids are transported to the liver by the portal vein, where they are metabolized or released into the general circulation. However, branched-chain amino acids are not metabolized in the liver, rather they are carried to muscle. Separate carrier transport systems are present for the absorption of basic, acidic, and neutral amino acids. 7 different transport systems are known that have overlapping specificities for different amino acids. For example, one transport system is responsible for the reabsorption of the amino acids, cysteine, ornithine, arginine, and lysine in kidney tubules. Amino acids are transported by the same Na+ dependent secondary active transport mechanism as for glucose transport. The carrier has receptors for both amino acid and Na+ and transports them to the interior of the cell. From the cells, they cross the basolateral membrane by facilitated diffusion. Pyridoxine, vitamin B6, is required for the absorption and transport of amino acids. L-amino acids are more rapidly absorbed than D-isomers. Defects of proteins digestion and absorption. 1. Achlorhydria, it is a condition characterized by a lack of ability to produce HCl, usually due to autoimmune destruction of gastric parietal cells. The pH of the gastric secretion fails to decrease below 6.5 after maximal stimulation. It is commonly seen with pernicious anemia. Digestion and absorption of proteins are severely affected in achlorhydria. 2. Steatorrhea, in individuals with a deficiency in pancreatic secretion, example due to chronic pancreatitis, cystic fibrosis, or surgical removal of the pancreas, the digestion and absorption of fat and protein are incomplete. This results in the abnormal appearance of lipids, called steatorrhea, and undigested protein in the feces.
3. Hereditary deficiency of enterokinase. This condition results in diarrhea, failure to thrive, and hypoproteinemia.
During infancy, it is managed with pancreatic enzyme supplementation. When patients become adults, they no longer need such supplementation, owing to the decreased anabolic demands and the autocatalysis of digestive enzymes. 4. Non-tropical sprue. Adult celiac disease/celiac sprue. It is a problem of malabsorption that results from immune-mediated damage to the small intestine due to ingestion of gluten, a protein found in wheat, barley, and rye, or gliadin produced from gluten. Common symptoms are steatorrhea, diarrhea and weight loss. 8.7 Digestion of lipids. Dietary lipids. Main dietary sources of lipids are butter, cream, cheese, oils, and animal fats. Highly refined oils, example vegetable and fish oils, contain an appreciable amount of fat-soluble vitamins A, D, E and K. Fats are best the form of stored energy in the body, mainly stored in adipose tissue. The main function of dietary lipid is to provide essential fatty acids and to improve the absorption of fat-soluble vitamins. Chemically, the chief dietary lipids are triacylglycerols, TG, phospholipids, glycolipids, and cholesterol esters. Adult man ingests about 60 to 150 g of lipids daily, of which 90% is normally TG. The remainder of dietary lipids are cholesterol, cholesterol esters, phospholipids, and fatty acids. In diabetes mellitus, the body first utilizes fats for energy production, when glucose oxidation is impaired. TGs are digested by a group of enzymes. These are lingual, gastric, pancreatic, and intestinal lipase. Digestion of lipids in the mouth. The digestion of lipids started in the mouth by the lingual lipase, which is secreted by Ebner's glands found on the dorsal surface of the tongue. Because foods remain for a short time in the mouth, digestion of TG by this enzyme is minimal. Digestion of lipids in the stomach. Little fat digestion takes place in the stomach by gastric lipase that degrades TG with short-chain fatty acids at optimum pH of 5.0. Gastric lipase is valuable in infants due to the high pH in their stomach and their milk diet with short-chain fatty acids, while it is insignificant in adults due to its inhibition by gastric acidity. Emulsification. Before digestion in the intestine, large clusters of fat masses are emulsified. Emulsification means the disintegration of large globules into smaller ones. Emulsification increases the surface area of lipid droplets. Detergent action of bile salts is the main affair in the process of emulsification. Emulsification is supported by the shearing action of mastication, gastric contraction, and intestinal peristalsis. Bile salts reduce the surface tension and prevent the aggregation of fat droplets. Digestion of lipids in the intestine. In the small intestine, digestion of lipids is carried out by the following enzymes. 1. Pancreatic lipase. It is secreted into the intestine and prefers to attack long-chain fatty acid containing TGS. It is the most important lipase in TGS digestion. It digests the primary ester bonds, positions 1 and 3, hydrolysing them into fatty acids and 2-monoacylglycerols. The 72% of resulting 2-monoacylglycerols are absorbed as such, while the remaining 28% are converted into 1-monoacylglycerols by isomerase. The presence of emulsifying agents such as bile salts and phospholipids are important for the action of pancreatic lipase. This increases the surface area of lipids exposed to the lipase enzyme. A protein cholipase secreted by the pancreas is required to stabilize the lipase to its TG substrate. 2. Intestinal lipase. It acts on 1-monoacylglycerols and converts 22%, out of 28%, into glycerol and free fatty acids. Thus, the end products of triacylglycerols are I2-monoacylglycerols, 72%. 2,1-monoacylglycerols, 6%. 2-glycerol and free fatty acids, 22%.
Figure 8.18 Lipolysis of triacylglycerol by pancreatic lipase.
3. Cholesterol ester hydrolase. It is responsible for the digestion of cholesterol. Cholesterol itself undergoes no digestion and is absorbed as such. Cholesterol esters are digested by cholesterol ester hydrolase into cholesterol and free fatty acids. 4. Phospholipases. Phospholipids may be absorbed as such or digested by various phospholipase enzymes such as A1, A2, B, C and D. They act on phospholipids hydrolysing them into free fatty acids, glycerol, phosphate and a nitrogenous base. Iphospholipase A1, it hydrolyzes the ester bond at position 1, primary ester linkage, of phospholipid. 2. Phospholipase A2, it hydrolyzes the ester bond at position 2, secondary ester linkage, of phospholipid. It converts the phospholipid into a lysophospholipid. 3. Phospholipase B, it acts on lysophospholipid. It can remove the fatty acid from positions 1 and 2 of the lysophospholipid. It is also known as lysophospholipase. It is an enzyme with a combination of both phospholipases A1 and A2 activities. 4. Phospholipase C, it is involved in the catabolism of sphingomyelin. It hydrolyzes the glycerol part leaving a phosphorylated nitrogenous base. It is present in hepatic lysosomes and also found in alpha-toxin of Clostridia as well as in other bacilli. V. Phospholipase D, it separates the phosphate part from the nitrogenous base. Figure 8.19 Action of various phospholipases. 8.8 Absorption of lipids. Micelles formation, it is an important process in fats absorption. Digestive end products of lipids are encircled by bile salts with their polar ends outside, to form spherical structures called micelles. A minimum 2 millimolar concentration of bile salts is necessary for micelles formation. Cholesterol and fat-soluble vitamins are also incorporated in the middle of the micelle. The size of a typical micelle is about 0.5 millimeters. The main function of micelles is to transport fatty acids and cholesterol up to the epithelial cell surface. Figure 8.20 Role of micelles in the absorption of lipid. Source: jasbci.biomedcentral.com. At the brush border of enterocytes, micelles release their contents for absorption. Bile salts turned back to be reused in the formation of new micelles. The last part of the duodenum and proximal part of the jejunum is the site of maximum fat absorption. These are also the site for resynthesis of TGS from fatty acids. The cholesterol, fatty acids, and monoacylglycerol passively diffuse into the columnar epithelial cells of the jejunum and ileum. From mucosal cells, fatty acids may follow one of the following routes. I. Fatty acids with 10C pass directly into the portal blood, and circulate as free fatty acids. 2. Larger free fatty acids are reactivated to the corresponding acyl CoA in mucosal cells, where resynthesis of TGS takes place. Formation of chylomicrons, the TGS and cholesterol esters with the help of phospholipids and protein coat, apolipoprotein B48, form a particle called chylomicron, which is 0.2 to 1.0 m in diameter. A typical chylomicron is composed of 88% TGS, 6% phospholipids, 4% cholesterol, and 2% proteins. They have transported in membrane-bound vesicles to the lateral cell membrane of mucosal cells. From here, they are released by exocytosis into the extracellular space. Some VLDLs are also synthesized by the mucosal cells. On moderate intake, 95% or more of ingested fat is absorbed. Transport of chylomicrons. From the sides of epithelial cells, chylomicrons enter the lacteal and are transported by lymphatics to the thoracic duct, which drains into the left subclavian. Before entering the tissues, TGS are hydrolyzed by lipoprotein lipase into monoacylglycerol and fatty acids. Monoacylglycerol is completely hydrolyzed by hydrolase to glycerol and fatty acids. Chylomicron remnants are cleared by the liver, where cholesterol is used for bile synthesis while fatty acids are used for phospholipid biosynthesis. Transport of fatty acids. About 10% TGS of in diet are medium-chain fatty acids, 8 to 10 C. They are absorbed directly into the mucosal cells from the gut without hydrolysis. In mucosal cells, these triglycerides are hydrolyzed by endoplasmic reticulum lipase to fatty acids and glycerol. Clinical aspects: excess lipids excreted into the feces are called steatorrhea because of lipid malabsorption from impaired lipolysis, micelle or chylomicron formation, or chylomicron transport. Orlistat, it is an anti-obesity drug that inhibits pancreatic and gastric lipase, resulting in about 30% blockage of dietary fat from digestion and absorption, leading to a reduction in body weight in some patients. Olestra, it is an artificial fat composed of sucrose, polyester and fatty acids. It is not degraded by gastric or pancreatic lipases and passes through the body undigested and unabsorbed. Excess use in foods may interfere with the absorption of fat-soluble vitamins. 8.9 Digestion of nucleic acids. Nucleic acids, DNA and RNA, are taken into the diet as a part of nucleoproteins. Good sources of nucleic acids are the tissues rich in cell nuclei such as the liver and kidney. Nucleoproteins are hydrolyzed by proteolytic digestive enzymes to nucleic acids and protein, which is usually a histone. Nucleic acids are dissolved in gastric chyme, where DNA and RNA are denatured by low pH. Most nucleic acid digestion takes place in the small intestine. Nucleases, DNase, and RNase present in pancreatic juice are released to initiate nucleic acid degradation. Nuclease, by the action of nuclease, denatured nucleic acids are hydrolyzed to oligonucleotides. Phosphodiesterase, it hydrolyzes the oligonucleotides to mononucleotides. Nucleotidases, phosphatase nucleotidases are present in the intestinal juice. It is a hydrolytic enzyme that catalyzes the hydrolysis of a nucleotide into a nucleoside and phosphate. This degradation of nucleotides takes place in the microvilli of the small intestine. Nucleoside phosphorylase, nucleosidase. The nucleoside is further degraded by nucleosidase, which separates the pentose sugar from the nitrogenous base. The nucleosides undergo phosphorylasis by phosphorylase to yield nitrogen base and ribose 1-phosphate or deoxyribose 1-phosphate. Membrane transport proteins bring these components across the membrane and into the capillaries of the small intestine. Purines and pyrimidines as well as some nucleosides are absorbed into the bloodstream. Nitrogen bases are then either degraded or salvaged for nucleotides synthesis. Purine bases are converted to uric acid, which is then excreted.
Figure 8.21 Digestion of nucleic acids, DNA and RNA, in the gastrointestinal tract.
8.10 Some important gastrointestinal disorders. 1. Cholelithiasis. It is the condition characterized by the presence of one or more calculi, gallstones, in the gallbladder. Gallstones, choleliths, are crystalline structures formed within the body by the accumulation of normal or abnormal bile components. Gallstones are the most common biliary pathology. Gallstones can occur anywhere within the biliary tree, including the gallbladder and the common bile duct. Obstruction of the common bile duct is cholelithiasis. Obstruction of the biliary tree can cause jaundice, and obstruction of the outlet of the pancreatic exocrine system can cause pancreatitis. There are many causes of gallstone formation. Some stones form when there is too much cholesterol or bilirubin in the bile. One type of gallstone, called pigment stones, tends to occur in people who have medical conditions that cause the liver to make too much bilirubin. Pigment stones are also more common in persons with liver cirrhosis and biliary tract infections. Gallstones are classified into cholesterol stone, most common 51 to 99%. When bile is supersaturated with cholesterol. Black pigment stones are largely composed of an insoluble bilirubin pigment polymer mixed with calcium phosphate and carbonate. Brown pigment stone contains calcium bilirubinate, calcium palmitate, and calcium stearate. Chances of the gallstone formation increase whenever static foreign bodies are present in the bile duct, example stents, or parasites such as Clonorchis sinensis, an infection usually acquired by eating undercooked freshwater fish, and Ascaris lumbricoides. Clinical features: stone blocking the opening from the gallbladder or cystic duct usually produces cramping pain in the middle to the right upper abdomen. This is known as biliary colic. The pain goes away if the stone passes into the first part of the small intestine, the duodenum. Acute cholecystitis occurs if the stone does not pass into the duodenum. Dyspeptic symptoms may coexist and be worse after such an attack. Gallstones are easily diagnosed by routine ultrasonography. Medical treatment: cholesterol gallstones can sometimes be dissolved by oral ursodeoxycholic acid, an epimer of chenodeoxycholic acid, but it may be required that the patient should take this medication for up to 2 years. Gallstones may recur, however, once the drug is stopped. Obstruction of the common bile duct with gallstones can sometimes be relieved by endoscopic retrograde sphincterotomy, ERS, following endoscopic retrograde cholangiopancreatography, ERCP. Gallstones can be broken by using a procedure called lithotripsy, extracorporeal shock wave lithotripsy, which is a method of concentrating ultrasonic shock waves over the stones to break them into tiny pieces. They are then passed safely in the feces. However, this form of treatment is only suitable when there are few and smaller-sized gallstones. Surgical treatment: cholecystectomy, gallbladder removal, has a 99% chance of eliminating the recurrence of cholelithiasis. Only symptomatic patients should be considered for the surgery. The lack of a gallbladder does not seem to have any negative consequences for many people. However, there is a significant proportion of the population, between 5 to 40%, who develop a condition called post-cholecystectomy syndrome, which may cause gastrointestinal distress and persistent pain in the upper right abdomen. In addition, as many as 20% of patients develop chronic diarrhea. There are 2 surgical options for cholecystectomy. Open cholecystectomy: this procedure is performed via an incision into the abdomen, laparotomy, below the right lower ribs. Recovery typically occurs after 3 to 5 days of hospitalization, with a return to normal diet a week after release and normal activity several weeks after release. 2. Laparoscopic cholecystectomy: this procedure was introduced in 1980. It is performed via 3 to 4 small puncture holes for a camera and instruments. The patient is usually released on the same day or one-night hospital stay, followed by a few days of home rest with some analgesics. Laparoscopic cholecystectomy patients can generally resume normal diet and light activity a week after release, with some decreased energy level and minor residual pain continuing for a month or 2. A reduced number of operative complications is one of the benefits of the laparoscopic procedure. 2. Peptic ulcer: the term peptic ulcer applies to mucosal ulceration near the acid-bearing regions of the gastrointestinal tract. It is a break in mucosal surface more than 5 mm in size and extends up to the submucosa. The main sites are the duodenum, first portion of the duodenum, and stomach 90 to 95%. Esophagus and reflux esophagitis, jejunum, and Meckel's diverticulum. Causes: Helicobacter pylori is the most important factor, accounting for 90% of duodenal and gastric ulcers. NSAIDs, nonsteroidal anti-inflammatory drugs, example aspirin, causes 30% of peptic ulcer. Hereditary causes are also significant, as peptic ulcers tend to run in families. Smoking and the use of hot spicy food are also involved in causing and aggravating peptic ulcers. Clinical features: pain in the epigastric region which is burning in character. Vomiting relieves the symptoms. On examination, there is deep tenderness in the epigastrium. Diagnosis: endoscopy is the investigation of choice for diagnosis of peptic ulcer. Barium meal, double contrast technique, is less commonly used nowadays. Treatment: general measures include no smoking, avoiding aspirin, avoiding alcohol and spicy fried food, taking full sleep, and elevation of all factors causing stress and tension. H2 receptor antagonists: these are competitive inhibitors of histamine at H2 receptors on the parietal cells. These are the first choice of therapy. Examples of H2 receptor antagonists are ranitidine, cimetidine, famotidine, nizatidine, etc. OAC regimen: a combination of omeprazole, amoxicillin, and clarithromycin is given for 7 days. Proton pump inhibitors: these are also called H+, K+, AT-PASA inhibitors, example omeprazole, lansoprazole, etc. Eradication of H. pylori infection, OCM regimen, omeprazole, clarithromycin, metronidazole, is given for 7 days, or an OAC regimen, omeprazole, amoxicillin, clarithromycin, is also given for 7 days. Surgical management. Surgical intervention is required in peptic ulcers in the following situations. I. Emergency, when the ulcer is suddenly perforated or associated with persistent hemorrhage. 2. Elective, in case of a complication due to gastric outflow obstruction or recurrent ulcer following gastric surgery. Types of operation may be partial gastrectomy or vagotomy. 3. Malabsorption syndrome. This occurs when the normal digestion and absorption of food are interrupted. Impairment can be for single or multiple nutrients depending on the abnormality. This may lead to malnutrition and a variety of anemias. Malabsorption constitutes the pathological interference with the normal physiological sequence of digestion, intraluminal process, absorption, mucosal process, and transport, post-mucosal events, of nutrients. Intestinal malabsorption can be due to I. Digestive failure caused by enzyme deficiencies. It is seen in pancreatic insufficiencies, cystic fibrosis, chronic pancreatitis, carcinoma of pancreas, and bile salt insufficiency as an obstructive jaundice. In the case of bacterial overgrowth syndrome, there is a proliferation of colonic-type bacteria within the small intestine causing impaired peristalsis. This leads to diarrhea and malabsorption. 2. Structural defects. These are seen in inflammatory bowel diseases, commonly Crohn's disease, gastrectomy and gastrojejunostomy, fistula, diverticula, and strictures, infiltrative conditions such as amyloidosis, lymphoma, etc., eosinophilic gastroenteropathy, radiation enterithes, systemic sclerosis and collagen vascular diseases. Short bowel syndrome. Following resection, diarrhea and or steatorrhea can occur due to a decrease in the area of the absorptive surface. 3. Mucosal abnormality, for example, celiac disease. 4. Infective agents, as in Whipple's disease, caused by the bacteria Trophirima whippleae, intestinal tuberculosis, tropical sprue, parasites, example Giardia lamblia, etc. V. Systemic diseases affecting the gastrointestinal tract, as in hypothyroidism, hyperthyroidism, diabetes mellitus, carcinoid syndrome, malnutrition, etc. Clinical features of malabsorption syndrome. Symptoms can be intestinal, predominates, or extraintestinal. I. Diarrhea, often steatorrhea is the most common feature. It is due to impaired water, carbohydrate, and electrolyte absorption. Latter also results in bloating, flatulence and abdominal discomfort. 2. Weight loss, growth retardation, failure to thrive, delayed puberty in children. 3. Swelling or edema from loss of protein. 4. Anemias, commonly from vitamin B12, folic acid and iron deficiency presenting as fatigue and weakness. V. Muscle cramps from decreased vitamin D, and calcium absorption, finally may lead to osteomalacia and osteoporosis. V. Bleeding tendencies from vitamin K and other coagulation factor deficiency. Management of malabsorption syndrome. Rehydration and replacement of nutrients and electrolytes may be necessary. Hospital admission may be required for parenteral administration, in serious cases. Pancreatic enzymes are supplemented orally in pancreatic insufficiency. Dietary modification is important in some conditions, example gluten-free diet in celiac disease and lactose avoidance in lactose intolerance. Respective antibiotic therapy is also required in case of infections. 4. Pancreatitis, it is the inflammation of the pancreas. It can be acute or chronic. I. Acute pancreatitis, the most common cause of acute pancreatitis is the presence of small gallstones, a pebble-like substance made of hardened bile that causes inflammation in the pancreas as they pass through the common bile duct. Consumption of alcohol heavily is also a common cause. Acute pancreatitis can occur within hours or as long as 2 days after consuming alcohol. Other causes of acute pancreatitis include abdominal trauma, medications, infections, tumors, and genetic abnormalities of the pancreas. Acute pancreatitis usually begins with gradual or sudden pain in the upper abdomen that sometimes extends through the back. In acute pancreatitis, the amount of amylase and lipase in the blood is raised at least 3 times the normal. 2. Chronic pancreatitis. It starts as acute pancreatitis, but when not treated well or heal, it gets worse over time and leads to permanent damage. If the pancreas becomes scarred during the attack of acute pancreatitis, it cannot return to its normal state. Symptoms of chronic pancreatitis are related to long-term complications, such as the inability to produce insulin, bleeding and inability to digest food. Treatment and management. Certain complications of either acute pancreatitis or chronic pancreatitis may require surgery or a blood transfusion. Some patients may need a nasogastric tube for feeding. Insulin shots may become necessary if the pancreas does not produce sufficient insulin. 5. Zollinger-Ellison syndrome. It is a condition in which a gastrin-secreting tumor or hyperplasia of the islet cells in the pancreas causes overproduction of gastric acid, resulting in recurrent peptic ulcers. The main signs and symptoms of Zollinger-Ellison syndrome are burning abdominal pain, diarrhea, acid reflux, nausea, vomiting, decreased appetite and weight loss. A cytoprotective drug, ribamypid, is used to increase gastric mucus secretion to treat this condition. Summary. Digestion is a biochemical process of hydrolysis during which large and complex food particles are converted into small and diffusible particles so that they can be absorbed easily. Absorption is the process of translocation of nutrients from the gastrointestinal tract into the bloodstream. Transport is the process of movement of absorbed nutrients throughout the body via the circulatory and lymphatic systems. At the cellular level, it encompasses the transfer of substances across the cell membrane. Elimination/egestion is the excretion of undigested and unabsorbed food through the feces, stool, via the act of defecation. Main digestive juices include saliva, gastric juice, pancreatic juice, and intestinal juice. Salivary amylase breaks down starch into dextrin and then maltose. Pepsin initiates protein digestion. It is secreted as pepsinogens, inactive proenzyme, by chief cells. Pepsinogen is activated to pepsin by HCl. It is most effective at pH 1.5 to 3.5. Trypsin is the main proteolytic enzyme of pancreatic juice. It also catalyzes the activation of all other enzymes such as chymotrypsinogen, procarboxypeptidase, and proelastase. Pancreatic lipase is the most important lipase in triacylglycerol digestion. It digests the primary ester bonds, positions 1 and 3, hydrolysing them into fatty acids and 2-monoacylglycerol. Bicarbonates of pancreatic and intestinal juice help in the neutralization of acidity of chyme. Fat emulsification is the process by which fat globules are separated into smaller pieces by the detergent action of bile salts supported by lecithin. The bile facilitates the intestinal absorption of fat-soluble vitamins, vitamins A, D, E, and K. Cellulose remains undigested but has many beneficial effects like helping water retention during the passage of food along the intestine, producing larger and softer feces helpful to prevent constipation. There are 2 mechanisms responsible for the absorption of monosaccharides. One is active transport and the second is passive transport, by facilitated diffusion. A small number of unchanged proteins such as peptones, proteases, and polypeptides may also be absorbed, as evident by allergy to some proteins. Amino acids are transported by the same Na+ dependent secondary active transport mechanism as for glucose transport. The end products of triacylglycerols are 2 monoacylglycerols, 1 monoacylglycerols, glycerol and free fatty acids. Micelles are spherical structures composed of digestive end products of lipids encircled by bile salts. The main function of micelles is to transport fatty acids and cholesterol up to the epithelial cell surface. Enzymes involved in the digestion of nucleic acids include nuclease, phosphodiesterase, nucleotidase, phosphatase, and nucleoside phosphorylase, nucleosidase. References. Exercise questions. For MCQ 1 to 4, see Part 1 of 2 of this chapter. MCQ 5. A 45-year-old obese and known hypertensive man, presented with complaints of recurring episodes of pain and heartburn starting from the upper abdomen and going up the center of the chest for the past several months. History of presenting complaints revealed that the heartburn usually occurred when he had very heavy and often fatty meals or when he went to bed immediately after meals. Which of the following hormones is responsible for the digestion of particular meals taken by this patient? Bomazine, cholecystokinin, gastrin, motilin, secretin. MCQ 6. Which of the following chemical substances is richly found in pigment stones of cholelithiasis? Bile salts, bilirubin, cholesterol, lecithin, mucin. MCQ 7. A 44-year-old fatty man presented with complaints of recurring episodes of pain and heartburn starting from the upper abdomen and going up the center of the chest for the past several months. History of presenting complaints revealed that the heartburn usually occurred when he had very heavy and often fatty meals or when he went to bed immediately after meals. Which of the following is one of the end products of the digestion of food that often causes heartburn in this patient? Alanine, glucose, glycerol, glycine, lysine. MCQ 8. A 35-year-old man consulted a GI clinic for complaints of indigestion and abdominal pain on intake of a fatty meal. After a thorough checkup and investigations, he was found to have a problem with bile salt formation. Which of the following chemical processes concerned with digestion is affected in this patient? Emulsification, esterification, hydrolysis, oxidation. Please write answers in the comments. End of Part 2 of 2 of Chapter 8. Thank you.